So first, I would like to thank the conference organisers for inviting me to come and speak today on a topic held close to my heart. It's really not a lecture, this is a tour. And what I'm attempting to do today is clear up a lot of things that optometrists, by the nature of their practice, are confused about. Terms like wet and dry age-related macular degeneration, a drusen, a pigmentary change, a retinal pigment epithelial detachment, choroidal neovascularization. You hear all these terms. When should we refer? When should we not? So before I even show you the first slide, I'm going to try and get everybody in this room never to use the terms wet and dry age-related macular degeneration again, ever. It's wrong, okay? Because if you have dry AMD, it might be just a few early soft drusen, and that doesn't cause any problem. Or it could be atrophic AMD, which is the worst type of AMD you can get, for which there's no treatment. There's only two types of macular degeneration. It's really simple: early and late. Early is drusen and or pigmentary changes, full stop, that's all. You have drusen or you have pigmentary changes. And late is either atrophic or neovascular. And I'll keep repeating that ad nauseum for the next 20 minutes or so. A lot of this is going to be very basic, but before I start, I'd like to disclose any financial interests I have. I am a recipient of research grants from the following companies: Alcon, which do eye caps; Novartis, which do Vitalux; MacuVision, which does MacuShield; Chemin Health, which is responsible for marigold extracts; Zeiss, which has a macular pigment measuring device; Maculometrics, which also has a macular pigment measuring device; the Howard Foundation; and Bausch & Lomb. In all of my relationships with all of these companies, I insist, and I've always been successful in securing scientific independence and editorial control. This is a picture you're all used to. It's a completely normal macula. So this is the nerve. These are the blood vessels. The whole thing is the retina, and the center of the retina is the macula. And behind the screen is the optic nerve, which leads to the brain. When we do a cross-section of the retina, this is what we see. Blood vessels, the most vascular structure in the human body. This is known as choroid. This is Bruch's membrane that separates the blood vessels from the retinal pigment epithelial cells. Now, if you remember from your undergraduate days, you have two layers in your retina: the neurosensory retina and the retinal pigment epithelium. When you get a retinal detachment, for example, it's just the neurosensory retina which peels off. It's not the retinal pigment epithelium, it's just the neurosensory retina. So, these are your photoreceptors. There are your discs, which are renewed every day. This layer, a unicellular layer, a single layer known as the retinal pigment epithelium, it has one job and one job only, and that is to remove waste products from the neurosensory retina and to provide nutrition to the neurosensory retina. And this is just some cartoon presentation. It actually is like this. If you look at the slide on your left, there's the choroidal blood vessels. There's the retinal pigment epithelium. It's called retinal pigment epithelium because there's pigment in it. And there's your photoreceptors. Now, that's your cross-section of your retina. A cross-section of your macula at the fovea is very similar, but you can see it dips there at the fovea, and that's known as the foveola. And that's because your nerve fiber layers splay out. If you see them, they're going in this direction. They're getting out of the way, so the light which comes in can, without having to go through these ganglion cell layers, hit the very sensitive and high concentration of cones to give you your central and color vision, which is essential and which is pretty much unique to primates, monkeys and humans. Now we're going to talk about age-related macular degeneration, now that we've looked at what a normal retina and a normal macula looks like. Now, there's two types. There's early and there's late. Early macular degeneration consists of drusen and or pigmentary changes. Late age-related macular degeneration is either neovascular or atrophic, and we'll go through them one by one. These are some drusen, very subtle in this case. You could barely see them. These are more obvious drusen. Drusen is just a word for white dots at your macula. There's some more obvious drusen. Here, we have even more obvious drusen, and sometimes you can get drusen outside of the macula. And if you can't see it on this photo, but on slit lamp, this patient does have one drusen right at the center. So again, a lot of people get confused by this. You know, drusen are like anything. They're a spectrum. You can get all sorts of different types of drusen. And these patients, because they just have drusen, they won't have any problems. At least they're not really aware. If you do subtle tests of visual function, like glare disability or contrast sensitivity, these patients will definitely have reduced visual function. But when you do your Snellen chart, a crude measure of visual, they'll be fine. And they probably won't have any subjective complaints at this early stage. But this is actually the time to intervene in terms of nutritional supplements and habit and changing habits. So if we look at these drusen under the microscope, what do we see? This is a druse here. And this is hyperplasia, irregularities of the retinal pigment epithelium. So it's just a big lump at the layer of the retinal pigment epithelium. And here's another one. And they have hyperplasia, which means overgrowth of pigment. And this is an important slide, because what this slide shows is that the drusen, when you use a special staining technique, they do stain with TIMP3. And in brief, long story short, I'm not going to go into the biochemistry of it. What this shows is that drusen are the result of oxidative stress. Now, when we use an even better microscope, an electron microscope, what we see is in age-related macular degeneration, in the retinal pigment epithelial cells here, you have these little vacuoles, little lumps. And what they are accumulations of lipofuscin. And lipofuscin is simply an age pigment. And what we see here is an atrophic retinal pigment epithelial cell which is lifted over a drusen. And if we look here, again, we see the age pigment and the thickened Bruch's membrane. So what I'm trying to demonstrate here is that the drusen are indeed correlate very well with the pathological changes. Now, I've mentioned what we have is two types of macular degeneration, early and late. One of the late types, I've said, is atrophic. And the atrophic type is simply wear and tear. And what you see at the wear and tear is you actually see through the retina to the underlying layer. And unfortunately, there's no treatment for this type. Now, if we go back to the drusen, what we see here is some soft drusen there. And when we do a fluorescein, we see some staining. No leakage, just staining. And when we look here, and this is an important slide, because what it shows here is very large drusen, soft drusen, and these are confluent. And this is a bad sign, because this patient will almost certainly develop neovascular age-related macular degeneration. If we go on here, sometimes if you look very closely, you can see discrete atrophic changes. So you can see through the retina, you'd see it better on slit lamp, to the underlying choroidal vessels. So what I'm trying to demonstrate by showing you all these different types of age-related macular degeneration is that there is a spectrum, that there's not just one type of druse, there's different types of druse. And they all have different prognosis. Soft druse, which are confluent, are bad news. These druse, and associated with subtle atrophic changes, are also bad news. Now, we're going back to atrophic age-related macular degeneration. And if you look very closely here, you can see through the retina to the underlying choroid. So this patient, in essence, at the macula, has no retina. And if we look very closely, there's normal retina, full thickness. Here, we see through the retina to the choroidal blood vessels. And if we do a fluorescein angiogram, we see scleral staining at the edge there, and we can see the choroidal blood vessels. So the analogy I make with my patients is, I say, if you have early macular degeneration, soft drusen or pigmentary changes, no problem. We'll stop you smoking. We'll get you onto appropriate supplements. And hopefully, you won't get late AMD. There's two types of late AMD. There's this type, which is atrophic. And I'm afraid there's no treatment anywhere in the world for this. There's nothing you can do. But the other type is neovascular. And the analogy I say is, if you have a carpet, and if you have a leak under your carpet, and you leave the leak there, the carpet fibers get destroyed. If you stop the leak, sure, there'll be a stain on the carpet, but the carpet fibers are not destroyed. That's neovascular. That's wet. But if you have the atrophic type, this type where you see right through to the layer behind it, you're actually seeing that white stuff there is actually sclera. What you're actually seeing is it's like your carpet is fraying so much that you can see through to the floor beneath it. And I'm afraid there's nothing you can do. So now we're going to look at some other terms you will have heard over the last few years. And one of them is known as a retinal pigment epithelial detachment. And there's no mystery here whatsoever. If you look very closely at this photo, you see a fixation marker. That's just an artifact from the camera. And if you look very closely, you get the impression there's a little lump there, that it's lifting out. And that's because there is. And it's because the retinal pigment epithelium, this layer here, has detached. It has lifted off Bruch's membrane, which is this black line which separates the retinal pigment epithelium from the choriocapillaris. And there's two reasons for this. One, it just happens. Or two, there's leaky blood vessels causing it. Now, if we do a fluorescein angiogram on this patient, what we see is we inject the dye into the arm, and the dye goes through the blood vessels. And if we look here, it's beginning to pool. And this is a typical finding of a retinal pigment epithelial detachment. In this case, there doesn't seem to be any new blood vessels. And the reason I say that is there doesn't appear to be any leakage. So whether or not you treat this with Lucentis would be a matter of debate. Some ophthalmologists would and some wouldn't. Now, this is, again, something you will have all heard about, but won't have seen much of. It's known as a retinal pigment epithelial rip. Now, if you look very closely, you'll see here that there's a dark piece of retina right beside a very light piece. And what has happened is, and this happens with a hemorrhagic retinal pigment epithelium detachment. So basically, the retinal pigment epithelium is lifted because of blood. And what happens is the actual retinal pigment epithelium, like a piece of elastic, breaks. And if you saw this on a slit lamp, what you would see here is that the neurosensory retina is actually intact over this. But I'm afraid this patient won't do well. Central vision will be lost. So people get a retinal pigment epithelial rip or a retinal pigment epithelial tear when they have a retinal pigment epithelial detachment, and for some reason in that particular eye the retinal pigment epithelium springs open, breaks, folds on itself, and central vision will be lost, and there's nothing anyone can do. So again, ad nauseum, to repeat, early AMD, drusen or pigmentary changes, change lifestyle. Late AMD, atrophic, which is wear and tear, you can see right through the retina to the sclera behind it, nothing you can do. But the other type of late age-related macular degeneration is choroidal neovascular membrane. In the old days, we used to call it subretinal neovascular membrane. And what happens is, here we see, there's all the photoreceptors, there's the ganglion cell there, there's the retinal pigment epithelium, but for some reason, Bruch's membrane has broken. And that, we know that Bruch's membrane increases in thickness with age, but especially if you have age-related macular degeneration, and then it snaps. And the choroidal blood vessels, the most vascular structure in the human body, are delighted because they can now grow into this space here. And that is a choroidal neovascular membrane, and that's all it is. If it's worse, and it usually is, and they actually don't just get under the retinal pigment epithelium, but they get through the retinal pigment epithelium into the actual neurosensory retina, and that is very bad news because this patient, unless treated very promptly, will get a disciform macular scar. But this is also bad. This is also a matter of time. So that's what choroidal neovascularization is. It's just inward growth of choroidal blood vessels. The reason, and this would be dealt with in my lecture this afternoon, the reason you get choroidal new blood vessels in age-related macular degeneration is because of overproduction of a protein called vascular endothelial growth factor, or VEGF. So what we do is we block the protein with an injection, but more of that later. So how does this correlate with actual histopathological changes? This again is a choroidal neovascular membrane, normal photoreceptors here, but if you look very closely, it's disorganized. It's a bit of a mess there, and you have some blood vessels. And that's because this patient has some scar tissue and choroidal new blood vessels. And this is a much more severe case. Here they have gliosis, which means scar tissue. That's all it means. When you look at a disciform scar, you're seeing gliosis, and complete disorganization. All the photoreceptors are gone. And this is precisely what we're trying to avoid. So how does the patient present? Well, the patient presents typically with maybe some hemorrhage. Sometimes you don't see hemorrhage. And you can do an OCT, and an OCT is great, and you have to do an OCT. But if you want to make a diagnosis of neovascular age-related macular degeneration, which is the only type that can be treated, you have to do fluorescein angiogram. So you inject some dye into their arm, and you watch the dye go through the blood vessels. And you can see this net-like network of blood vessels, and the hemorrhage masking it there. But this is very important. From here to here, it increases in intensity. That means it's leaking. It increases in intensity. So we see an outline of it there, and it's much whiter, much brighter there. So this is an active neovascular, choroidal neovascular membrane, which happens to be classic. Don't worry about the terms classic and occult. They're not important. We've got into this habit of classifying them as such. But classic simply means, all it means is you can see the edge of it. Occult means you can't. You don't know where it starts and begins. So this patient would benefit from very prompt treatment with Lucentis. Now, in this patient, again, a bit of hemorrhage, a bit of elevation, which you can't appreciate here because it's not stereoscopic, but if you looked at it on the slit lamp, it would be coming out to you. You inject some dye into the arm, and again, you have a little bit of staining in these early pictures, but it increases in intensity, which means, yes, it's actually leaking. We have to stop the leak. In this case, we've subretinal blood. That means the blood is just under the retinal pigment epithelium. And this is kind of interesting. When we do the fluorescein angiogram, here it's very mottled. So yes, it is staining. Yes, it is leaking. But this is what we call an occult choroidal neovascular membrane. An occult choroidal neovascular membrane simply means you're not quite sure where the edge of it is. Is it here or is it there? This was important when we used Visidyne, when we used photodynamic therapy. It's no longer important whether it's occult or classic. You just treat it with Lucentis or Avastin or whatever your particular hospital treats it with. This is a more serious case. This patient has exudates. That means the leak has been there for a while. And if you look very closely there, you see some subretinal scarring or fibrosis. And when we do the fluorescein angiogram, what do we see? A very mottled appearance. Again, you couldn't put your hand on your heart and say, oh, the edge of the membrane is here or here. So this is an occult choroidal neovascular membrane. In essence, they don't do as well as classic, but they still do well with Lucentis compared to non-Lucentis, compared to non-treatment. In this patient, again, there's your fixation. And if you look very closely, you get the impression that it's lifted. And when we do the fluorescein angiogram, sure, we see nice leakage there, but it's sparing fixation. So this is a juxtafoveal, juxta, because it doesn't involve fixation. It's just off-center, juxtafoveal choroidal neovascular membrane. And in the old days, up to about 10 years ago, what we would do is we would laser it. And if you were very skillful, you could ablate, shut down the membrane, and this patient retained vision. Sure, they will have had a scotoma, but central vision will have been retained. And as you can see here, following treatment, there's no leakage. And this is what we're trying to avoid, a disciform scar. And if you don't treat neovascular age-related macular degeneration, you will get disciform scar with loss of central vision, loss of reading ability, loss of social independence, inability to recognize faces or watch television. Nowadays, what we do is we treat these patients with choroidal neovascularization, be they occult, be they classic, be they subfoveal, juxtafoveal, or extrafoveal. The management nowadays is very, very straightforward. Very little thinking is required. You treat them with intravitreal anti-VEGF therapy. Intravitreal anti-VEGF therapy, as you'll find out this afternoon, is associated with a 90% chance, 90% chance of stabilization or improvement vision. So 50% get stabilization, 40% get an improvement, and 10% it actually continues to deteriorate. That compares with a 98% risk of loss of central vision if you do nothing. But the key to treatment is rapid access. Go back to the analogy of the leak under the carpet. If you have a leak under your carpet and you stop the leak, the carpet fibres will be fine, a bit stained, but fine. If you leave the leak there for a few weeks, the carpet will be destroyed. So in order to treat neovascular age-related macular degeneration, they need to be seen within a week or two, not a month or two. And they need to be seen in a centre where they're processed and the injection is given within a week or two, not a month or two. It can't be phoning the local eye department, arranging for an assessment, and then they're called back 2 weeks later for the angiogram. And the consultant looks back at the angiogram and 6 weeks have passed, you've missed it. Rapid access is the only way of preventing blindness in neovascular age-related macular degeneration. I'll be talking later about the role of optical coherence tomography and fundus fluorescein angiography in cases of neovascular age-related macular degeneration. And this is just a typical example of an OCT. So when they have the neovascular age-related macular degeneration, you can see it's lifted with subretinal fluid. And as we treat them, the vision slowly improves and you get restoration of your normal foveal anatomy. The commonest cause of failure in cases of neovascular age-related macular degeneration, besides starting to treat too late or not treating frequently enough, is ceasing treatment too early. Okay, so it's the one disease where more is less. What I mean by that is if someone walks in with neovascular age-related macular degeneration and you give 3 injections and you're all happy with yourself because you've got vision back and you've got your normal foveal anatomy back, and you stop, 3 months later you'll be back giving another 3, and then 3 months later you're much better off giving 6 or 7 every month religiously, and then it's much more likely never to regress. Thank you very much.